Okay, welcome back. This is section 4 of 8 and the conclusion of head-to-toe systems assessment.
Cardiovascular full assessment is done at 8 o'clock. What's done at 12 and 4 is the heart sound and heart rhythm. So you have to do the full assessment at 8, which include your cardiovascular symptoms. This could be edema, this could be headaches, could be dizziness, nail bed color, capillary refill, if there's any clubbing present in your fingers, your extremity temperatures, things of that nature. Pacemaker. Not all patients all have pacemakers. This is only if it applies to your patient. You want to make sure to go ahead and fill it out as fully as possible just once during the shift, unless someone like the nurse practitioner or one of the surgeons might come to the bedside and change your settings. Then of course you would go ahead and update your documentation, but for the most part you'll go ahead and just document it the one time in the shift. You want to state what kind of pacer you have, if it's transcutaneous, if it's permanent, if your patient's 100% paced. Well, how many wires? Is it 2V, 2A? Is it 1V, 1A? Is your pacemaker on? What are the settings? What kind of mode is it on? Is it DDD, VVI? I know all these things might not make sense right now because you haven't had the opportunity to have patients with pacers, but it all will come together. Pulses. Pulses is another one that is pretty much assessment versus documentation. If your patient is awake and oriented, you could go ahead and assess and document your full assessment at 8 o'clock. And if they are walking around, you could, at the end of the day, no changes, then you could go ahead and leave it at that. However, if you have, let's say, for example, an open heart surgery patient or a vascular patient, you're going to go ahead and assess your pulses a lot more frequently depending on your orders. For the most part, we do it either Q2 or Q4. And we go ahead and check our radial pulses, our post-tibial pulses, and our dorsalis pedis pulses. If at any moment in time you have a normal pulse and then you're having a harder time finding it the next time you assess it, or you need to go get the Doppler, these are very important changes. So you want to make sure and keep your team updated of these changes and document appropriately. Edema assessment is, again, one of these things assessed and documented. Assessment, you will constantly be looking at your patient. So if you do see them swelling up a little bit throughout the shift, then you're going to go ahead and document as the patient changes. However, if your patient, you come in and they are just generalized edematist and they stay that way during your shift, you could go ahead and just chart at that 8 o'clock. You're going to do it as specific as possible. So if they have generalized edema, you're going to say, what the edema is, if it's mild, moderate, if it's pitting, things of that nature. If it's localized, then you'll say in which area of the patient it's actually localized to. VTE risk. VTE stands for venous thromboembolism risk. Very important. We do not want our patients to throw a thrombus. So you want to keep an eye out for these risk factors. So any change in skin colors or temp, chest pain, cough, difficulty walking, pain, anything like that, you want to make sure you document and let the team know. For the most part, if there isn't any, you just put none. And anti-embolism devices, your patient must have their intermittent pneumatic compression devices on throughout the shift. The only time is in the morning when you come on in, get in the habit of taking them off for 30 minutes. So what I would do when I was at the bedside is the moment I walked in, I would take them completely off. And by the time I went, I checked my monitors, made sure everything was clean at the bedside. I did my head to toe assessment and walked out of that room. I could go ahead and place them back on and the 30 minutes had been off. So once you do that, you could go ahead and document. If the patient has any foot devices, multipodos boots or anything like that to stop for foot drop, you would go ahead and document here. Ventilator associated pneumonia, it's our VAP and our VAP bundle. This is for intubated patients only. You need to fully document at 8 o'clock assessment. After that, you will come back here at your 12 and 4 to fill out the oral care portion of it. Our patients are at high risk for getting pneumonia when they are vented. So we have to make sure to do that oral care every 4 hours. And if you don't document it, it did not happen. So please make sure to do oral care every 4 hours and come back to this section to document. In addition, you will notice that in your morning medications, you will more than likely have chlorhexidine as the mouthwash for these patients. So go ahead and do that and document it at 8 o'clock that you actually use chlorhexidine as a mouthwash for your patient. So to document your VAP, you're going to go ahead and document fully at 8. If you're going to go ahead and document the head of the bed, the elevation. Most of our patients are 30 degrees. Oral care is done. Chlorhexidine is used at 8. Patient is on DV prophylaxis. Most of our patients are on heparin or Lovenox. Peptic ulcer disease prophylaxis, Protonix. If you perform sedation vacation, which you should in the morning unless there is some type of contraindication, if your patient actually tolerated or if they did not tolerate the sedation vacation. So you would just go ahead and fill out everything appropriately. And again, you would come back at 12 and 4 just to go ahead and document oral care for those intubated patients. Artificial airway and intubation. For the most part, if your patient is intubated, the respiratory therapist will go ahead and document for the intubation. However, for tracheostomy tube, we go ahead and document our assessment at 8 o'clock. A full assessment is expected to be done. If anything does change, of course, you would go ahead and update it. Here, the main thing that I wanted to show you, tracheostomy tube and activity, you would go ahead and choose assess. For tube status, you want to make sure your inner cannula is in place, that it's patent, that that it's secure, sutures are either intact or there's ties around the actual trach. You want to make sure to document the length of your tube, especially if it's an extra long tube, then we have to be specific with that because we need an extra one at the bedside. If there's any type of dressing, if it's clean and intact. If there's any type of leak in regards to your tracheostomy tube, if it was actually, the position was confirmed either by x-ray or by breath sounds, and if there's any type of drainage around the tracheostomy site. Now, throughout your shift, you do have to perform trach care once a shift, and it needs to be documented. Remember, if you do not document, it did not happen. So this is where you would come back and document your tracheostomy care. So instead of putting assess where tracheostomy tube activity, you would go ahead and put whatever it is that you did with your tracheostomy. So you would actually change the inner cannula, you would clean the stoma site, you would go ahead and suction, and you would probably change the ties. Respiratory. Respiratory, a full assessment at 8 o'clock, including breath sounds. Now, breath sounds are what we're going to go ahead and document and assess every 4 hours. So for the full assessment, just any respiratory symptoms that the patient may have, labored breathing, anything like that. Respirations, you want to say if your patient looks like they're using accessory muscles and it's labored or it's unlabored, the pattern. You want to go ahead and assess the chest motion. Is it symmetrical? Is it not? Do you have a barrel chest? What kind of oxygen therapy is your patient on? Is there any crepitus? Is the patient coughing? Are they not? Are they able to clear the secretions? How much secretions does this patient have? How often are you suctioning? What kind of secretion does your patient have? Is it thick? Is it thin? Is it just clear or is it mucousy? All these things make a difference in our patients, and if we document properly, we could catch changes very quickly. Incentive spirometer, or as it's also called IS, it's extremely important for our patients. We go ahead and provide our patients with the IS promptly after they become extubated. You want to make sure you teach them how to use it correctly and encourage it as often as possible. In the bare minimum, have them do it at least 10 times within the hour. You should be charting this every hour that they do it. I know it could be overlooked, but it's extremely important for your patients. Please explain to them the importance. Let them know that this will help them prevent respiratory infections, prevent those pneumonias, prevent lung collapse, and prevent reintubation. Get that IS from the Omnicell the moment your patient is extubated. Show them how to do it correctly, encourage them to do it, and make sure you document. Chest tubes. If your patient has a chest tube, this is the way you would go ahead and add it. So you would click on that little diagram that we call dynamic group. Pick the tube number that you would designate for the specific chest tube. State its location. Either it's a med, a pleural, is it posterior or lateral, if it's left or right, and the French. So whenever you're getting report, you always want to make sure that you know the French or your chest tubes. You would press OK. And now you would have the section where you could actually document for your chest tube. So activity, if this is the first time and it was just inserted, then you would put inserted. If your patient already has had a chest tube, then you press assessed. Chest tube output, your chest tube outputs should be documented. Technically Q4, however, it is based on the output. If you do have a lot of output, well, then this patient is bleeding, then of course you're going to be documenting that hourly. However, if this is an old chest tube for a patient that is still in and they barely are getting any type of output, then it's okay to go ahead and document it every 4 hours. You would then just go ahead and document this completely, as much as information as possible. Make sure you keep up to date. If you know the insertion date, it's very important to go ahead and include that, so it could keep counting down the days of how many days the chest tube has actually been inside of the patient. You want to document the connectivity. Is it to water seal 20 centimeters of suction? Is it to air? What is it to? If you see any bubbling, you have to assess your chest tubes. If you see any air leaks or any bubbling, you want to make sure you let the team know. Well, what does your dressing look like? Everything in regards to the chest tube is extremely important, so please document it. Full assessment at 8, and then just the output at 12 and 4. GI and bowel sounds, again, full assessment at 8, and then bowel sounds, you'll come back and assess at 12 and 4 and document those assessments, just the bowel sounds. So you're going to go ahead at 8 o'clock and assess any GI symptoms. If your patient's awake alert and tells you that their abdomen is tender, you could go ahead and document that. If they're having any eating difficulties, do they have a good appetite? Do they not? Are they NPO? Any nutrition factors, are they on TPN? Are they on enteral feedings? Do they have skin breakdown? What does their abdomen look like? Is it soft? Is it distended? Is it protruding? And be as specific as possible. However, once you already do this for your full assessment at 8, you no longer have to go back for 12 and 4 unless there's changes. Bowel sounds, however, you will assess every 4 hours. So you're going to go ahead and get your stethoscope and listen to all 4 little quadrants and make sure you document that assessment at 8, 12, and 4. I want to point out that you cannot assess absent bowel sounds unless you have auscultated each quadrant for 5 minutes and have not heard any bowel sounds. At that point, you could state that the patient has no bowel sounds. Very important as well is to please document stool. Gastric tubes. If your patient does have an NG or an OG and it's connected to suction, you please get in the habit of checking it the moment you come into the room at your initial assessment. You want to make sure it's connected, that it's actually suctioning, that you mark the canister. Every 4 hours, you should be documenting the actual gastric output. Get a marker and check off where your gastric output begins, and every 4 hours. You're going to do a full assessment at 8 o'clock. You're going to say the activity, assess it, where's the location of the gastric tube, what type is it, the gastric output. if there's any residual, has the placement been confirmed by x-ray or by auscultation, so everything that is pertinent to your patient. Enteral tube is very similar. So this is pretty much for our Dubhoffs and things like that. You would go ahead and click on the dynamic, pick whichever nostril or oral or abdominal wall, whatever the location may be for the tube, and what kind of tube it is. Obviously, it could be a nasogastric, nasal duodenum, a jejunum. We have multiple tubes, and depending on your patient, you would just go ahead and pick the appropriate one. For this example, it's an oral gastric tube, so we go ahead and state that we inserted it. The position, you want to make sure you know the marking on it and that you actually document that, because we want to go ahead and assess if maybe that tube came out or it's been pushed in. Now, tube intake, if you are feeding your patient, then you're going to go ahead and document the amount of feed that that patient's receiving hourly. And of course, throughout the day, you're going to be in and out of the room, so you would physically look at your patient and make sure that the tubes are in place. However, you don't have to document unless something changes. Tubes and drains. So again, this is a surgical unit. You will come to know and come to see many different tubes and drains coming out of your patients from every orifice. So if your patient does have some type of surgical tube or drain, you would go ahead to your navigator bands, find surgical tubes, click on that dynamic group little square, and go ahead and add it. You would call it tube 1, state what type of tube it is and its location. If it's a surgical drain, same process. You would click on surgical drains, click on that dynamic group square, name your surgical drain, what kind it is, and the location. Once you've done these things, you could go ahead and document in these sections. So these are some of the tubes and drains that we have. So again, just kind of depending on your patient, you would go ahead and document a full assessment on these drains at 8 o'clock. GU, you're going to perform a full assessment and documentation at 8 o'clock. These things include just kind of, does your patient have a Foley? Are they voiding? The description of the urine, genital anatomy, is the patient circumcised or not? Things of that nature. In regards to the urinary catheter, if your patient does have a catheter, please make sure to go ahead and assess it. We do have to perform perineal care once a shift, so you're going to go ahead and document that. Please do not forget to go ahead and document when you insert a Foley, when you exchange a Foley, or when you discontinue a Foley. Okay. Also, you should be dating your actual Foley bag when you do insert, so don't forget to do that. If your patient does not have a Foley and your patient's anuric, you want to go ahead and check to see if your patient has orders for bladder scan. This could be Q shift, Q24, Q72. You'll go ahead and bladder scan your patient, and you will document appropriately in the bladder scan area as you see here above.